There's Choll Kim here from San Diego, California. We're getting ready for an interesting case. Patient all the way from New Mexico convinced me to do two totally different types of surgeries on one sitting, which kind of makes sense because for him to come back to another general anesthetic and do another surgery, if I was in his shoes, I would have a hard time with that. So after much ado, he convinced me to do the surgery and have to fix essentially four problems. First is random discrimination at 3-4, and central disc protrusion with an annular tear on the left side and on this side. We confirmed them as pain generators through targeted diagnostic injection. And then he's got this, a Bertolotti's lesion right there. That joint is not supposed to be there. You can see it right there. And that's been injected with an anesthetic, and that improves the symptoms. It's really good that we're doing the right thing for this patient. Let's take our time. We'll do the endoscopic part first. 2 Band-Aids, and then computer navigation to very carefully reach in here to create a separation between those false joints that are kind of painful. 2 totally different types of setups. Well, we are doing it. It's a lot of stuff in here. But I asked myself, what would I do if this was me or my family member, which is the most important question of all? I would make them come back again. So, wish me luck. Okay, 3-4 chromatodiscogram time. Shot. Gotta save that mega shot. X-ray. That is a caca-poo-poo disc shot. X-ray. Oh, I see it leaking out right there. It's going like, it's dribbling down like a little tail. So cute. Okay, so that's the bone, that's the neuroforamen, and it's the whole thing is just filled with scar, which I'm going to have to peel off from the bone, starting at the L4 pedicle and working my way up toward the nerve. Look how good that looks. Everything's scarred. Look at all these adhesions right there. Picking gum out of shag carpet, that's my specialty right here. This is a foraminal disc protrusion with foraminal stenosis, so it's semi-empty right there. But here's the nerve. It is so stuck down that that tiny little bump is adding up to a lot of nerve irritation. Okay, another Choll Kim special, the articulating curettes. Look at this, I'm like, so sneaky, let me in. This is exactly what we do in open surgery too. Dissect free the nerve from all the surrounding tissues. Just really hard to do endoscopically because it just is, okay? Oh, that feels good. See that redness right there? That's granulation tissue. It's not supposed to be red here. It's supposed to be pure white, like a dense wall of collagen. And there's no way I should be able to just get in with this little device. Usually you have to use a mechanical device. But if it's incompetent like this is, it just falls in. Look at that. Boing! The nerve is just to the left of me and at 12 o'clock. So at 9 o'clock and 12 o'clock. Look at all these caca-poo-poo pieces. It's going to come flying out of here as soon as I make a little bit of room. Ooh, I'm glad we're doing this level. There's the bone spur, which in and of itself is not causing anything, but if the bone spur presses on a disc, it will do a lot. Look at this Goomba. It's like my punk teenage kids. It's not going to come out without a fight, I can tell.
This instrument, there's no way you can do the surgery without it. Everyone uses an instrument like this. It's an electrical probe. Strictly speaking, it's a radio frequency probe, but it's also kind of like bipolar electrocautery. There's a little gap between those two probes. It makes it bipolar. So theoretically, the electricity only goes between that gap. But you know electricity and how it could be. If it wants to, it will find a little pathway and go outside those two little openings and shock something every once in a while. This part of it is probably not pathologic. I'm just cleaning things up, making sure there's no more loose pieces in here. There's the bone spur. There's L bump. And yes, it starts bleeding more from within the canal once I do the decompression. The nerve is oh so close to me. Right there, move away. And look how this tissue right here is right underneath the nerve. So I'm going to scooch the nerve out of the way with this cannula. Isolate that bump and make it disappear with the laser. I'm just doing a little bit of cleanup. Okay, here's the Stevie, that's a navigation pointer, also a probe. So right there is the neural foramen. It's cleared all the way to even more medial than that. Look at that. Yep. I can get all the way north. There's the nerve root. We're going to look at it from above in a second. It will bleed. Because all nerves are surrounded by fat. There's a bunch of scar tissue right there that I can take out. And then the bone spur right there. No more. Look at that. It's totally flat. Same thing with that bone spur. Going all the way out and medial. Right there. All done. Look at that. All clear. Here's the exiting nerve root. It's going to fall right over all that stuff. Happy as can be. Right there. Right there. Look how red it is, though. That's the edge of the bone and the annulus. That is the facet joint. That's Wagner's arch. And you can just see the space right there. Like a long time, next level time. Okay, I'm at 4-5. Shot. Shot. There it is though, I think. Shot. You see a leakage? This is in the middle, so it's not going to stick out as much. Okay, step one, create like a little footprint. Because soon it's going to look all weird in here. Just going straight out laterally. All the way to that corner. And this thing should be straight up and down, just like it is. And if I need to, I will use navigation or intraoperative imaging. Let me see the regular pituitary. Okay, I've got the nice bony footprint and bony window. That's the hard part. I want to leave as much of the ligament as possible, but I got to get in the canal. San Diego pimple popping maneuver time. There it is. Oh, that's creepy, isn't it? If you're not creeped out right now, you're a brave soul. Check that out. There's that little blue thing. The only way that can be blue right there is if there's a tear, because I injected this from the other side through a transforaminal approach. That's my story. I'm sticking to it. Come on, baby. Daddy needs a new pair of shoes. It's like my punk teenage kid's not going to let me in without a fight. Probably scarred from the previous surgery at the other level. The dural tube is not mobilizing very easily. Not yet, anyway. Oh, look at that blue. Yes. Look at that. Look how much harder it is to pop in. Not that. Oh, there's the pimple popping maneuver.
That's a good one.
Not one of our biggest pimple poppers, though. Yep, look at that. Oh, look at that. It's a little, I don't know, monster, I guess.
Looks like the trees in the rocks. Look at that, yeah.
That felt good. That piece of nucleus, the gelatinous thing that we just squirted out, that was pretty superficial, probably trapped in the annular tear. Because the rest of the disc seems pretty healthy and stable. Look at that right there. It's taunting us. Okay, I'm right at the recess. That's exactly what I thought. And look how far posterior I am. Look at that. That's not inside the nucleus. The nucleus is like way down there in the middle. This blue thing goes all the way to the posterior line. Look at that. I'm going to get a little bit more under surface here just to cook that. Then I'm going to look medial toward the canal where all the nerves are. It'll bleed a lot more. But this is looking good so far. There's the dural tube right there. Look away. There's more stuff in the middle. Which makes sense because the little protrusion was right smack in the middle, right here. There's the dural tube. Not injured, that's also a good thing. I'm just saying. Oh yes, likey long time. There's the lesion, right there. Look at right next to the neuroforamen, so you have to be so careful. Okay, I'm right on it now. Okay, I'm drilling and drilling right down this lesion. You can see it in the left upper, right upper, and left lower image. Then I'm right inside that Bertolotti's lesion, but it is not moving at all. It's fused. I see the line right there, the fibrous line. This is rock solidly fused. It is not moving at all. I don't think we should take this down. I'm just going to clean up this whole area. Okay, I'm going down the other side. Oh, so gently and carefully. Without trying to get seasick. There are a bunch of ligaments right here. I can just feel it snapping back and forth. So I wonder, because when you do that injection, that's basically where you're numbing up this, like, all this soft tissue area. So if the bones are fused, I think it's still probably possible this area is painful, not because of the articulation, but because of inflammation, like many other things that we do. We have the nav dilator. Yep, same thing. A really thick ligament right here. Doing, doing. And then below that is the Bertolotti's lesion. But on top of that is this gnarly ligament. He's so good. Okay, I see the line, kinda. But The navigation says it's right there. That feels like the line. Yep, it's perfect. I'm going to go a little bit deeper, but it's not moving at all either. Not at all. But there was that big ligament in front of it. Alrighty, I'm in the left side of the Bertolotti's lesion. It is not moving at all. I can't find a gap, and it's unequivocal where I am, both looking down here and on the navigation. So I don't think unfusing something that's fused is going to be a good idea. But there was another big, thick ligament right above it. I wonder if it's more of a tendonitis that you've been having right there because of the abnormalities. Oh, surgery's all done. Look at this little interesting configuration of dressings. It's adorable. But it's always better to make multiple little incisions than one big long incision. Almost always. Everyone's making fun of me because I have OCD just even putting this on. But I can't help myself. I didn't take my OCD medicines on surgery days because I want to be OCD. The surgery went beautifully. I have some interesting things to tell you about the Bertolotti lesion, but I'm expecting you to feel a lot better. And we're all praying for a speedy recovery. So best wishes.